It's my pleasure to introduce the first speaker, Professor Vidal Melo. He's a full professor at Columbia University in New York, and he will give a lecture on protective ventilation in the operating room, fact or fiction.
Thank you so much. I would also like to thank Jan for the invitation to come here. This must be the most beautiful venue I've ever been through in terms of a symposium. It's really great. Thank to Anne also for all the organization. And we are going to talk about protective ventilation, facts and fiction. And the topic came because of an editorial that we wrote on this paper that was done just about a year and a half ago, where the authors were trying to see if there would be any difference between tidal volumes of 6 and 10 mLs per kilo projected body weight and PEEPs of 5 or 8 in orthopedic surgery, kind of big cases done under general anesthesia. They actually did a very interesting thing because they did a 2x2 factorial design so that they would have all the combinations. And because these treatments are within the scope of practice, they did not consent each patient. They just randomized each block per week, and they would use that for the patients in that week, and then the next week, and so on and so forth. And with that, they could do this in a big number of patients with the primary outcome of essentially oxygenation in the first hour, the saturation FiO2 ratio. And I said a very big number of cases, they saw an SF ratio of about 353, which is kind of low normal, expected, and they did not see a significant difference between this. Because of the large number of patients, this is a strong result of equivalence, yet it led to this thought, well, does it matter? So it doesn't matter what we do, and etc. And I think that when we talk about the lung, right, and we are talking about mechanical ventilation, it's kind of nice to step back a little bit and have a little bit of a big picture, right? In the lung, the main function is gas exchange. So it needs to be very thin to allow for oxygen to come in the blood and to allow for CO2 to leave the blood. At the same time, if you're, running the marathon in the Olympic Games, or if you're running away from a predator or towards a prey in the savannas of Africa, right? You need to have tidal volumes of 2-3 liters. So 35 mLs per kilo of your projected body weight, actually. Blood flows of 35 liters per minute. So this organ needs to be very strong. And actually, these people here are not dying of ventilator-induced lung injury at the end of the race there. Does it look like they're doing that? It doesn't, right? So what's up with that? And the extracellular matrix is actually the stress bearer in the lung, not the cells themselves. And during normal tidal volumes, the elastin component of that extracellular matrix, and at higher levels, at the limit of high lung volumes, collagen, that's sort of wave-like during normal tidal volumes, but stretched at the end. And those retain the maximum stress. So the epithelial and endothelial cells are adhered complexly to this matrix, and with these adhesion complexes, they receive signals that then change enzymatic function and gene expression. So when you touch that button there, actually, you're not just kind of expanding the lungs, you're really dealing with the tissue and the gene and subcellular structure and going back to the lung and either causing good or bad things, right? And another piece of information is related to what we just talked about. If you now simulate mechanical ventilation at large stretches, and you put these levels of stretch here in the x-axis, changing volume by initial volume in different lung regions, measured in vivo with some special imaging techniques, and you put in the y-axis a measure of regional inflammation, also in vivo, actually, even if you have high stretches, 3 times the increase in lung volume, there is a relationship, but it's pretty small. There's not much inflammation that's triggered. Now, if you give endotoxin, for instance, and cause a systemic inflammation, now you amplify that quite a lot, 7 times actually. And of course, the cases we do are things like this, right? Where systemic inflammation is very frequently present. And then when we superimpose add mechanical ventilation there to a lung that's kind of like this, then problems may happen. And by the way, this lung here is completely histologically normal. Do you know what this thing is? The residence and etc. This is atelectasis, right? So it's a normal lung, but it doesn't look normal, and probably if it's ventilated kind of differently, it may cause problems. Now, when we are talking about protective ventilation, what's the story? Protecting from what, right? And actually, very interestingly, 62 years ago, when this paper was published in the New England Journal of Medicine, the word was exactly the same. They wanted to, they wanted to protect against shunt, against hypoxemia. There was no PEEP in the machine at that time. You should use tidal volumes of 15 mL per kilo. And after this, history for decades of this type of approach, until we realized a number of things, and today we learned that there is a problem actually, and that lungs do get injured by excessive pressure, excessive volume, atelectasis, by the biological response, cellular and cytokine response to stretch, like I was kind of talking about, and more recently, even this concept of energy type of injury associated with the lungs. Now what? And then we have, sort of these resources here to deal with this and do something. And one of the first really strong evidences that this would matter in the anesthesia setting, in contrast to the ICU setting, was this paper here about 12 years ago by the French group that essentially compared, during abdominal surgery, a group that received tidal volumes of 6 and 8 mL per kilo and PEEPs of 6 and 8 to a group that received no PEEP and 10 to 12. They said that this was the practice of several French groups at the time. And essentially, what they showed was a phenomenal amount of effect, or a third drop in the pulmonary and extrapulmonary complications, very reduced number of pneumonia, atelectasis, need for non-invasive ventilation, sepsis, and length of stay in the hospital. Now, this is a very different group of patients, and if you see here, and I'm not quite sure if you can see there, is these patients, 8 to 18% had sepsis after abdominal surgery. There was an anastomotic leakage in 12 to 22% of the cases. So this may not be exactly the case that you have in your hospital and etc. Anyway, for this group of patients, that mattered, and that made the point. Well, that's not fiction. This does have an effect. When we looked at this by big data type of approach, almost 70,000 patients, and we defined the protective ventilation as a combination of PEEP above 5, plateau pressure below 30, and tidal volumes below 10 centimeters of water, definitely the odds ratios for complications when this set of settings are together was below 1, suggesting that they would be protective in terms of big pulmonary complications, pulmonary edema, pneumonia, need for intubation, ARDS. And interestingly enough, also, in addition to this, is the fact that one of the main correlates there was actually the driving pressure, the difference between plateau and PEEP that was very much associated with those odds ratios for those big complications that I talked about, with a takeoff in this range of about, on average, 12.5 to 14 centimeters of water. Tidal volume in itself was not that much associated with it in this group. And actually, the lowest range, not significant from the other, being, somewhere between 7.5 and 9.5 mLs per kilo of predicted body weight. So it was not a surprise for us that more recently, in a prospective study, this group here compared exactly in the OR 6 to 10 mLs per kilo, major surgery, with a composite of PPCs in the first 7 days of the postoperative period, and essentially there was no difference between those two tidal volumes. Very different from actually the ICU type of approach, right? that found other results. So, and no significant differences also in the secondary outcomes. One way to think about this also that we looked at on our data and almost 200,000 patients, and we related the standardized elastance, so the inverse of the compliance, to the risk of those major pulmonary complications, is that if you see the light blue curve here, which is for tidal volumes below 8 mLs per kilo of predicted body weight, there is a relationship between elastance and the risk of those complications. So these are the rigid lungs here, and those are the more compliant lungs. But notice that this relationship is not as strong as that relationship, which is for tidal volumes that are above 8 mLs per kilo. So this group here, or this extreme here, are exactly the patients that would mostly benefit from lower tidal volume. The other side, those that are very compliant, actually might be hurt. And this range here, which is around the compliance of 40, 50, that actually seems that doesn't matter much. And perhaps these are the majority of the patients we take care of, or a good range of the patients we take care of. Now, the story for PEEP became a little bit more complicated. Became a little bit more complicated. And this was studied at fixed levels in different situations. For instance, obese patients, 4 to 12 centimeters of water PEEP, patients that are mildly obese or normal, 2 to 12, or in the ICU in patients who do not have ARDS. And in all these large studies, actually, there was no difference between the two extremes, suggesting somewhat of an equivalence of those approaches in these patients that were otherwise ventilated with normal tidal volumes. One important thing to think about this, though, is that you should not conclude from this that PEEP doesn't have an effect, right? What you should conclude is that, well, I may not be using PEEP to avoid the pneumonia in 7 days from today, or avoiding reintubation, but that PEEP has physiological effects during the case, and that if you need those physiological effects to improve compliance, to improve oxygenation, that's okay, that exists and it's present in most of those cases. So you need to differentiate and understand well the result of what the results are telling us. And Dr. Lagier in Marseille, in a multi-center study, he approached cardiac patients. And actually, he did an open lung type of approach using a PEEP of 8 throughout the case, including during cardiopulmonary bypass. So he persuaded the surgeons to deal with a PEEP of 8 during bypass. And if you do cardiac, you know what I'm talking about. In this situation, comparing to a PEEP of 2, actually, he also saw an equivalence in terms of complication, but there was, in addition to this, he also made measurements from the pulmonary veins, the blood that was coming directly from the lungs, that there was even a signal of SRH, epithelial injury, in the cases that received the higher PEEP. So, you know, we may overdo in some situations about this, and we need to be careful about how to approach the different situations. And one important concept in this situation is exactly the concept of transpulmonary pressure, right? The pressure that really distends the lungs. That pressure is not the airway pressure, but the difference between the airway pressure and the pleural pressure, what's inside and what's outside the piston, in a way, right? So what's inside the alveoli and what's outside the alveoli. And if we are talking about mechanical ventilation, at end of inhalation, that's the pleural pressure, and end of exhalation, that's the PEEP. And during surgery, we have several things that change that pleural pressure, that pressure outside. So if you had patients like this, and these are some of my patients actually, right, the pleural pressure here is 15, 20, 25 centimeters of water. So if you're using a PEEP of 10 in that situation, 10 minus 25 is minus 15. We allow for lung collapse, atelectasis, related injury. If, in contrast, we're dealing with this situation here, or cardiac surgery here, where the lungs are open to the atmosphere, now the pleural pressure is 0. And a PEEP of 10 is a transpulmonary pressure of 10. And it's a different situation. So we have to be active in what we think about this. In the way we think. Does this happen? You bet it does. So for instance, here's a measurements in which we use esophageal balloons as a surrogate of pleural pressure. And this is right after intubation here, where the green is the signal coming from esophageal balloon, the pleural pressure, and that is below the blue. So pleural pressures below airway pressure. Once you do pneumoperitoneum, transdermal position, and etc., the green becomes higher. Negative pressure and atelectron, and etc., susceptibility for lung collapse. And a pictorial view of this, in this approach that uses the maximal compliance type of PEEP setting, so the PEEP set to maximal compliance, which is associated with usually a positive transpulmonary pressure in lungs that are in animals, but similar to those of humans in a surfactant depletion type of model. And you notice that this is the same animal with that PEEP setting of maximal compliance or the ARDS net table type of approach. And you see that very clearly, this is different from this is different from this, right? For the same type of approach. And actually, more recently, we took a look at this using some imaging approaches to show is actually that when you set PEEP to that maximal compliance, what it does is that it finds the point that essentially the rate of increase in lung collapse with lowering PEEP and the rate of increasing overdistension going up in the PEEP is increased. So that point is somewhat of a compromise of those at the regional level. Now, this was applied then in thoracic surgery. And this is a group from Korea that studied then patients with normal BMI, low stage cancer, ASA 1s and 2s, most of them, and segmentectomies and lobectomies for VATS, video-assisted thoracic surgery. That, the surgery lasted for 2 hours and the one-lung ventilation 1.5 to 2 hours. And they saw somewhat of an equivalence when they used somewhat of a low PEEP or a PEEP titrated to maximal compliance, minimal driving pressure. In this other group also studied this. This is a group from Spain, Turkey, Italy, and etc. And I'll go into a little bit more detail here. They use it during the 2-lung ventilation, something kind of conventional, 8 mL per kilo and a PEEP of 4. And during 1-lung ventilation, they either used the PEEP of 4 or they did a very structured optimization to minimal driving pressure by doing this stepwise recruitment and then a decremental PEEP titration, finding the PEEP for best compliance, setting that PEEP there, and checking compliance. If the compliance dropped by more than 20%, take it again. These patients also received postoperatively high flow nasal cannula if they were hypoxemic, essentially, for the first 6 hours after surgery. This group had ASAs of 3, about 50 or more than 50%. About a fourth of them had COPD, they were smokers. They also had mostly lobectomies and segmentectomies. In addition to that, their surgery was 3 hours. The time of 1-lung ventilation, 2.5, almost 3 hours. They got, about a liter of fluid, and almost half needed vasoactive drugs during the case. In this group of patients, the effect was very remarkable. It was almost more than double the effect in terms of reduction of postoperative pulmonary complications. And to the point, right, that these authors concluded that this should be the standard of care in 1-lung ventilation of thoracic surgery. So residents, when you go back to the thoracic surgery, in the next case, that's the standard of care. That's what they say. Cardiac surgery postoperatively also, if patients are hypoxemic, below 250 PF ratios on arrival in the ICU, a very aggressive, I would call, intervention in terms of open lung showed to actually reduce the high-grade complications. Notice that this here is a PEEP of 30 for 1 minute in 3 cycles, kind of bearing after cardiac surgery. So if one would do this, would have to do it with a lot of care. Anyway, shown here to have a reduction in the high-grade complications, actually. Finally, in terms of other settings, we have done sort of big data type of analysis to show that even when accounted for other factors, FiO2, increases in FiO2 are related to increases in pulmonary complications those big complications that we talked about, pneumonia, pulmonary edema, respiratory failure, and that respiratory rates also, when corrected for other factors, were also associated with the increased odds ratios of those pulmonary complications. The discussion behind this being the discussion that this could be associated with that increasing mechanical power, meaning more cycles of stretch done in the same amount of time, potentially resulting in injury. There is a lot to discuss about this concept, so I'll be glad to discuss it if required. But I think that overall, one good concept to have in mind is that of the pressure volume curve of the lungs, that kind of has this shape, starting from a collapsed lung here, with a low compliance, delta V over delta P, initially at low lung volumes associated with a de-recruited lung, that then goes to a higher compliance region when the lung is evenly recruited, and again to a range of hyperinflation when you have excessive distension of the lungs. And our job as anesthesiologists is to keep the lungs in that range there, and we do this, avoid barotrauma and avoid atelectrauma, by setting PEEPs in the ranges that I mentioned to you, sort of those moderate ranges, and limiting FiO2s and doing recruitment when necessary. At the same time that we limit tidal volumes and plateau pressures with those ranges of tidal volumes and driving pressures that I also mentioned during the presentation. So, in summary, it is a fiction to think that we know what protective ventilation is for all the numbers, right? And actually, protective is sort of a misnomer. Everything we do in medicine should be protective, right? Protective blood pressure management, protection, protective general anesthesia, and et cetera, and et cetera. But we don't know magic numbers. And we know also is that the numbers from the ICU do not directly apply in the OR. That there is a need to know specifically what we should do in the OR. But we do know that mechanical ventilation settings affect outcomes, that those values there are important variables, that this has been proven to be relevant in those situations that I exemplified in several of them, yet that there are ranges of mild to moderate clinical practice that are entirely acceptable and that can be modulated according to our clinical acumen during the case. And as a consequence, mechanical ventilation in the OR requires its own set of measurements, and that this protection very likely will change with the patient's comorbidities and characteristics, and also with the case. And I'll stop here, and we'll be glad to take questions.